So we're going to open up the conversation to yourselves to take questions or comments from the floor. I think we've had insights into different ways of putting together service models. I think we've also had insights into people's leadership and how they've gone about challenges in their own environment. But it's over to yourselves, really. Questions from the floor. Yes, please.
Whittington Health. We are an organisation that has some element of primary care provision, community services and hospital services. And I just wanted to say, Alberto, your talk was very inspirational. And we are 3 years in, and I listened recently at the King's Fund to a German presentation where they said their journey had taken about 7 years. So I have 2 questions. One is the length of time it creates to create the change that they have created. And secondly, could he explain a bit more about the capitative system? Because one of the challenges is around the money, the incentives. Thank you.
El cambio de mentalidad, la verdad es que se está produciendo todos los días. Esto es un camino que empezó con la integración de la primaria y el hospital, pero para mí no tiene final.
So just to answer your first question about how long the change took, he said that it's an ever-evolving change because actually it's a change in mindset that begins, then you go through the organization a bit, but it's still progressing.
¿Pero por qué? Porque, por ejemplo, nosotros hemos ido cambiando nuestra propia mentalidad. Al principio fue el hospital y la primaria.
Because even for them, they needed to change along with it. So with the beginning, it was the primary care and the hospitals.
Luego fue trabajar conjuntamente los profesionales.
And then all of the professional body together.
Utilizar los sistemas de información para tener unos objetivos comunes.
And then use IT and then get all of the objectives aligned.
Ahora estamos descubriendo que ya con una historia de más de 15 años informatizada,
even with 15 years in the running, they're still building.
Debemos de establecer estrategias lo más individualizadas posibles a cada ciudadano.
And they're still continue segmenting to get personalized as possible for each one of the down to the public, so each one of the citizens to have a segmented view.
En la famosa pirámide de Kaiser ya tenemos identificados la población de riesgo.
So Kaiser's pyramid of risk, they've mapped out the segments accordingly.
Y esto es un camino que lo interesante es que para mí no tiene final.
So the interesting part for him is that it doesn't have an end, that it is continually evolving.
El modelo capitativo incluye todos los gastos, incluye la construcción del hospital.
So the construction of the hospital, it includes the construction of the hospital.
Y todas las inversiones necesarias tanto en el hospital como en primaria para el periodo del contrato.
So for the duration of the contracts, all of the hospital costs as well as the primary care costs.
En Valencia la duración del contrato son 15 años más 5.
So in Valencia the contract duration is 15 years plus 5.
En Madrid son 30 años.
In Madrid it's 30 years.
A mí no me gusta la duración de Madrid, creo que es demasiado largo.
He doesn't agree with how long the duration of the contract in Madrid is. He thinks it's too long.
Porque la sanidad cambia y va a seguir cambiando mucho en los próximos años, con lo cual 15 años a mí me parece una buena fecha.
Because of the ever-evolving needs of health, 15 years is long enough.
Incluye todos los gastos de personal, todos los gastos de medicación.
It includes the costs of medication and of the personnel.
Salvo la medicación de primaria que se hace por receta.
Except for all of the prescription medication done in primary.
Pero por una decisión del gobierno. Yo si me dejaran decidir, yo creo que debería de estar incluido.
But that's a decision made by government. He believes that it should actually be included as well.
En Madrid, por ejemplo, no se incluye la primaria.
In Madrid, primary is not included.
¿Por qué? Pues porque el gobierno tuvo miedo de incluir la atención primaria en el contrato.
Government was afraid of including primary into the contract, not into the contract.
Hay que respetar las decisiones del gobierno
And you have to respect those government decisions
y convencerles con el buen trabajo de que el camino de la integración asistencial y que el modelo capitativo nos tiene que hacer cambiar la visión de la organización de la sanidad.
and through creating credibility that the organization is working, then hopefully changing the mindset that the integrated model is the way forward.
Before we leave it, I just want to pause on that point when he said 15 years with 5. I mean, the opportunity of different models of care is very clear in the 5-year forward view. What's silent at the moment is how you operationalise, and the opportunity I think that Ribeira Salud had to transform their system in the knowledge that they had a 15-year contract gave them a completely different ability, in my view, to changing their systems. And our annualised tyranny of effectively having to make short-term decisions rather than invest now to save later, it would have been incredibly difficult, I think, for Ribeira Salud to achieve what they've achieved if they had a very short contract. And I just want to bring in Richard here because, of course, the other point about the voluntary sector is the wasted energy that a lot of very, very capable suppliers have in chasing next year's funding as opposed to having the ability to have longer term arrangements. And I think it's probably one of the most important bits of the afternoon about making change happen is this recognition of longer term relationships with suppliers. I don't know, Richard, whether you want to comment on that.
I completely agree, of course. And I think one of the things that we find is that politicians are just not willing to engage in looking at beyond the next election and making some of the commitments that are required. We've done some economic modelling at Scope that shows for every pound invested in supporting people with moderate care needs, you get £1.30 back in the longer term. There are examples of people who, as local authorities, have raised the eligibility threshold. I know someone who lost their care support package as a result of an increased eligibility threshold. As a result of that, they ended up losing their job and they ended up on out-of-work benefits that cost more than the social care support they were getting in the first place. But it requires the investment now. And so, if there is going to be really effective integration investing now for the future, then they've got to look beyond the sort of narrow definitions that exist at the moment and that 5-year cycle.
I mean, before we leave this point, I just wonder, we've got a couple of people I know in the room from Monitor, and I'd be interested in just that point about their view of taking a longer-term perspective in terms of contracts over that kind of period and whether or not that's something that they have a view on. So I know we've got Mark over there. Sorry, Mark, put you on the spot. Alberto.
Yo quiero insistir en que probablemente si nosotros nos comparamos con el sistema público tradicional, nosotros a los 2 años ya teníamos resultados mucho mejores. Pero que lo que le vuelvo a insistir es que, para que lo entienda, que a medida que profundizas en la gestión y tienes más capacidad, es cuando te das cuenta cuántas cosas más podemos hacer.
So just to emphasize the point that within 2 years you can turn around a lot and see a lot of benefits. It's just that when you continue, you go deeper into the issues and you find out how much more there is left to do. So it's not to say that you have to aim for 15 years, it's just to make the point that in 2 you can do quite a lot still.
Thank you very much for that opportunity. I don't know quite where to start. Couple of thoughts. I think the benefits from this approach, it's almost self-evident. I mean, this is as the previous question said, it's very inspirational. There's clearly huge benefits from this approach. The idea of attempting to get at those benefits without a longer-term structure around it, I can't imagine how that could work, and whether it's a 5-year contract, 2-year contract, 15-year contract, 30-year. I mean, it sort of all depends. But I can't imagine that you can have a serious attempt to do the sorts of things that this model does. And in a previous conference, Montefiore and the Bronx have achieved without some longer-term contractual wrapper. So from a monitor perspective, you know, we're very, very clear that the status quo is probably a bad place to be. All the indicators are heading in the wrong direction. We've signed up Foursquare on the forward view. The alternative I don't think is particularly attractive. And so we need something like this, and it needs the commitment and leadership to provide the conditions so these sorts of innovations can be brought to bear, I would have thought.
Thank you, Mark. So other points, other questions? Yes, please.
Hello, hi. Dr. Alberto's discussion was really, really interesting. I suppose my question is, because your payments capitated payments are fixed and weighted per head of population, how do you deal with the issue of risk sharing? Because if you're a larger organisation, you can sort of absorb some of those financial risks better than if you're a smaller one. So the question is, how did you adjust for that? Or did you have to at all?
No, la verdad es que si pudiéramos volver a cambiar cosas, desde luego, por ejemplo, el gobierno quería una cápita única y no una cápita, por ejemplo, en función de la edad o en función de la dispersión de la población.
So the government was asking to have a singular capitated system, not one that was segmented by age group or smaller or larger populations initially.
Y con lo cual el riesgo es un riesgo que asumimos como empresa, el que, bueno, en función de la población que cubrimos, pues tenemos que, en fin, adaptarnos y para eso la palabra flexibilidad es muy importante.
Flexibility is the key, and it's a risk that actually they had to assume themselves, so it was something that they took upon themselves.
Sin embargo, para mí hay tantas oportunidades, y es lo que yo siempre intento trasladar, de que podemos hacer en el sistema mejor las cosas, que al final te das cuenta que hay muchas posibilidades de mejora.
So there's so many opportunities to improve the system as is, that there's always a way of making improvements inside the system.
¿Por qué cada hospital tiene que tener un laboratorio y no podemos tener un laboratorio para 10 hospitales? Si es un problema de logística y de transporte.
So back to kind of shared services in logistics. With laboratories, for example, it was the example, like bringing things together.
Es un problema de tecnología, logística, transporte.
So thinking more about logistics and transport and IT as main levers and cutting out and making things efficient.
¿Por qué no aprendemos de otros sectores en los que el almacenamiento no es un problema y todos los hospitales y los centros de salud tenemos que tener grandes almacenes con grandes stocks?
So we need to learn from other sectors and from other industries like warehousing, for example, and how we store things. How do they improve things? How can we improve things?
Los sistemas de información, por ejemplo, nosotros simplemente enviando un aviso con el móvil, como decía Alan Milburn, la población sabe cuál es la demora en tiempo real en las urgencias, tanto en atención primaria como en el hospital.
So already using technology like mobiles, so why can't you connect to your patients by mobile so they already know the times that they require either from primary care or in hospitals just to connect in a different way?
La gente que viene a nuestro hospital y la urgencia que haya sido atendida es leve, nuestro sistema le comunica que en el caso de haber ido a su centro de salud hubiera sido atendido en tantos minutos.
So with their systems, they actually provide them the patient comparative data, so that they know that if they had been in a different hospital at that exact time, this is the time difference that it would have taken them. Oh, primary care, sorry, not hospital.
Con lo cual, el riesgo compartido es la cápita, es una transferencia de riesgo del gobierno a nosotros y es una gestión de ese riesgo. Pero lo que hemos aprendido es que podemos hacer muchas cosas para disminuir el riesgo.
So the government transfers through the capitated state onto the group, onto the company, and then it's up to the company to manage it and think about the efficiencies that you can do within it.
So just to sort of illustrate that story a bit better, that probably emerged, which I thought was staggering. So if you need emergency care or urgent care, you can text, and effectively it will tell you the waiting times for care in the hospital at the primary care centres across Alzira. So it'll say 2 hours, 50 minutes wait in the hospital, 50 minutes at the primary care centre. And with that simple way of giving the communication back to people, they'll orientate themselves and make choices about where they want to go. Very similar to sat-navs and traffic sort of control. And it's just incredibly simple, but it's made a big difference in that system. Can I ask you to just say two points about the rest? One is the public-private nature, because you have, as a private company, had an injection of capital to make change. And I know that's something that if you have a longer-term guaranteed supply, there's an opportunity to bring in partnership resources. And the other was just to make clear to everybody the point that the resource you have is actually only 80% of that which was previously available. So you've taken a 20% reduction in what's been spent in other parts of Spain for the same service and delivered better outcomes.
Nosotros funcionamos como cualquier hospital público, con los mismos criterios, no trabajamos nada para el sector privado.
So we still work like a public hospital. So we're, from the public eye, they still perceive us as a public hospital, not from a private point of view.
A mí personalmente no me gusta mezclar lo público y lo privado. Nuestra compañía solamente trabaja para el gobierno.
So I personally don't like working both public and private sector. I only work for the public sector.
Y en relación al coste, el coste es, el gobierno nos paga un 25% menos de lo que le cuesta a él la gestión de sus hospitales.
Okay.
El gobierno nos paga un 25% menos
The government pays them 25% less.
Del coste de sus propios hospitales.
So then they would pay for one of their public hospitals.
Y para mí lo que es importante es, en la generación de valor público, es que todas las innovaciones que hacemos están a disposición del gobierno, porque nosotros formamos parte del Sistema Nacional de Salud.
So it's actually all the benefits that they're giving into society, they're benefiting from themselves. So government's feeling the effects of the benefits that they're injecting into society.
Es el concepto de, para mí, que quiero mucho insistir en ello, es el concepto de generar valor público desde el sector privado.
So it's going back to the point that he was making about generating public value.
No solamente es ahorrar dinero, no es un tema financiero, sino es una contribución a poder mantener el sistema público en el futuro.
So it's not only about money, but actually creating sustainable public sector in the future.
Okay, let's open up more questions from the floor. I have a question for you. Yes, please. John.
To what extent is the training of your own staff essential to your model?
Nosotros lo primero es que nos hemos nutrido, nos hemos podido captar y fichar y atraer talento. Para nosotros es muy importante atraer talento, retener talento y descubrir talento dentro de la propia organización. O sea, atraer, retener y desarrollar.
So it's one of their founding blocks that he's presented before, is that they need to attract, retain, and actually develop the people that they have within the organization.
Nosotros, por ejemplo, ahora estamos desarrollando un programa, yo ya tengo más de 50 años, tenemos un colectivo de alrededor de 40 años muy potente, pero ahora estamos trabajando con la gente de 30 años porque serán los líderes del futuro.
So just a generational point then, he was just making a point that he's 50, he's got people around him that are around 40, but that he's thinking about the next generation and how they want to work in the future and getting their input into that.
I'll pass on to Richard as well in terms of your experience of sort of staff management and recruitment and developing people. You know, one of the issues that I think people have looked at the voluntary sector and is sort of freed from some of the constraints of national pay negotiations and things like that. So obviously the values and the support for staff, but also the way in which you are able to be more flexible around staff roles, and any comments you've got in terms of how that fits.
There are, and I won't name them, there are charities that will subsidise their commissioned contracts with charitable income so that they can pay staff more money. And I just think that's wrong. I think it drives poor commissioning, and I don't think that's the role of what we should be about. And so one of the challenges we have is that we've got to be providing the services that are funded, and there are commissioners that you know, we're under a lot of pressure, for example, to you know, to pay more money, to pay a living wage, but there are commissioners that won't commission us to pay that. And so actually if we apply those principles, which I think we should, a lot of those constraints still exist. And we all know there isn't enough money in social care. It's very difficult to pay the kinds of salaries we would be wanting to pay. And it's very difficult to retain people within that sort of that care and support world. What we have to do is seek to ensure that we've got the resources to be able to reward people in other ways, you know, with better training and development, career progression, and things like that. But a lot of it comes down to the extent to which you apply the principles of what you're here for as an organisation and where you use the charitable income, and therefore a lot of those constraints do actually exist.
Yeah.
Una cosa que quería añadir es que en nuestro modelo los beneficios están limitados al 7,5% de rentabilidad.
So just another point to add is that because of the system, the capitated system, it's limited to for 7.5%. The benefits are basically capped because of the constraints.
Y yo creo que eso es interesante porque es un modo también de equilibrar la visión de la empresa y la visión del gobierno.
And they've actually taken it as an interesting point because it's a way of balancing the vision of the government as well as the vision of the organisation. So
I'm going to come out to the audience and sort of challenge you a bit now, because I think there's a lot of interest in capitation-based approaches as a new way to organise services, and probably deal on you know, quite quickly with some of the perverse incentives between funding different sectors. In the 5-year forward view, there are two options. There's the MSCP or MCP, the multi-specialty community provider, the idea being that population health management built from primary care practice upwards. And then there's the PACS, which is the idea of primary and acute care services, care systems, where effectively, a bit more like Alzira, where it was a hospital provider coming out. Now, in terms of leadership, you might argue it doesn't really matter. I can see, knowing the tribalism of the NHS, that those two options, given it's very permissive, are ones where you could see quite interesting debates between a primary care-led move to capitation and a hospital move to capitation. And I'm just wondering how you see this in the context of your own local areas, and whether or not people have a view about, is there an optimal model? Does general practice intuitively understand population health better than hospitals? Is general practice too small with small lists and, you know, coming together? Because I think that's going to be the journey that people will be debating quite hard. Idea to make it happen is who's going to take the lead in different areas, and how are your collective leadership sort of approaches in different parts of London going to tackle those two potential options. And I just wonder whether anyone started to think it in that way from your system or wants to comment. Oh. Tim.
Yeah, in Lambeth and Southwark, we've been working on this for quite a while, and I think it was the providers were almost promoters of the idea of capitated budgets. But recently, the pull has come more from the GPs and the CCGs. So I think we're sort of getting there. The issue is about how to share risk, because some of us are billion-pound organisations and others aren't, and so there tends to be a suggestion that the billion-pound organisation should bear all the risk, and I think we're working hard. And I don't know if Adrian wants to say anything, because I think he's deeply involved in this. We're working hard to find a middle ground, aren't we?
So we'll get a mic. Adrian, I know you didn't want to say anything, but you've now been told you have to. So.
Thank you for that. I think one of the important points that you've raised there is the ability to bear risk, and I think a lot of what we're talking about at the moment is, how much risk should sit with commissioners, how much risk should sit with providers, and how we shift it, and who is able to bear risk. Clearly, scale is important to this, and we've had the conversation of that already. My understanding, because we've talked earlier about accountable care organisations, and my understanding, if you look across the world, that many of those globally are actually based within primary care, and that is the kind of the functional unit of organisation, and it has grown, and the secondary care has been added onto it, rather than being a secondary care that's added on the primary care. And I think that's the tension that you're questioning in the two models that are laid out in the 5-year forward view. Is it a sort of primary care up or a secondary care down? And I think there are global examples to follow. If you ask who understands their population better, as a GP and a clinical commissioner, the answer is one you might expect. I think we do have clear experience of knowing our practice population, and we're getting better at understanding the population of our borough.
I mean, we've not had much conversation about primary care. For obviously, it's always difficult to get primary care leadership together. Based on the business models, we have the LMCs, of course, are very supportive, I think, in London. But it's interesting that where GPs have come together with federations, my experience so far across the country, not just in London, is that they've largely been organisations that sat on top of separate practices with their population list, and they've come together to try and win community services contracts, rather than effectively say, well, let's put our lists together and have a bigger population on which to take a capitated budget. So, the logistics coming primary care upwards are quite challenging if you say, no, we stay as independent small business. Well, not the independent bit is a red herring, stay as small business. But but any other views from other parts of London about this kind of, if capitation is going to be, I'm particularly interested in local authorities as well. I know we've got John somewhere. John, where's John Powell? Is John around? Hi, John, you're right at the back there. I mean, no one's kind of referenced local government as a potential basis for a significant capitation approach, and yet there you are with the capitation and the strategies for well-being of a population. What's your view of this kind of newfound idea of capitated budgets in healthcare?
Yeah, so John Powell, Director of Adult Social Services in the London Borough of Redbridge, but I'm also the Vice Chair of the London ADAS branch as well. So in that context, I can give a view across a number of authorities. I guess one of our key factors here is about the importance of making sure that we are resourced appropriately to meet the needs of the individual people. And one of the things that's certainly been key for me about this afternoon has been the opportunity to listen and hear about the person's and the citizen's voice. Because equally, when we're talking about how we fund the services that we need to change, we have to bear in mind the individual needs of those population and fund it appropriately. And I think that's a challenge for us within London particularly, because we've got different levels of deprivation and different levels of resource that's allocated within the local authorities, but also within the health economies that we serve. And I guess the key priority for me is about how we can work in partnership, and it's interesting to hear, you know, the way in which colleagues from other authorities, both within CCGs and other provider organisations, and indeed the voluntary sector, are working closer together now, and actually trying to think differently about how resources are allocated to provide the services. So I'd welcome an opportunity to see where we can identify the level of need, allocate the appropriate level of resource to meet the need, and then work together across the health and social care and voluntary sector and independent sector markets to try and deliver. The key point for me, I guess, is about this coming back to the individual voice of the person and listen to the patient, because actually it's quite fascinating for me that when you comment and talk to individuals, they say, you know, actually we talk about the NHS, and we hear about CCGs, we hear about the CSUs, we hear about NHS England, we hear about NHS Public Health, and actually what we do know is the council. So if you ask them, where do you get your social care? They come back to, well, I live in Redbridge, or I live in Barking, or I live in Havering. So there are some things that I think collectively we can learn, where we can work closer together, and that has to include the resources as well.
Yeah.
And if that's about an individual budget based on an individual capitation, then that's something we could work with.
Okay, can I just do a sort of straw poll? How many people currently have something in their system where they are trying to operate a capitated approach? It might be for frail elderly or whatever. How many people are currently working on something now? Not very many. How many people think within 2 years you'll be operating with a capitated budget, slightly, you know, which is more of the MCP PACS idea? Not quite 50% of London. I think the aspiration in the forward view was 50% of the country will be covered by one of these models. Interesting. I wonder why. I mean, given that we say the current system doesn't quite deliver the incentives that we want, whether or not the status quo, maybe you've got a better way than capitation. I don't know. I'm interested in those people who are not thinking of it. Are you happy? Yes, please. Yeah.
So for me, there's a more general comment. I mean, to create an integrated care organisation is going to take incredible leadership and a phenomenal amount of management. And do we actually have the capacity to do that across 50% of the country within a short period of time?
I don't know if there are any responses to that, those people. Yes.
Thank you. Well, I think one of the very important points you made, and I like the statistics, is that it's not about the organisation. People don't need to know what the organisation is, and I would question whether we always need an organisation. What we need is the delivery of a service. And I think there are other ways of approaching this and saying it's about organisational redesign or transformation. There are things that we can do that do not need the creation of new organisations. I think one of the examples of things like alliance contracting that may give the illusion of a single seamless service.
Yeah, sure. Okay. Open up to any other sort of questions. We move away from the capitated budget about some of the other things that we've heard of. I was particularly interested, Richard, in and actually listening to you. You were challenging my false perceptions, but they were prejudice really. When you made the point about that you did so strongly about charities changing their service delivery, and I'm kind of confessing, put myself. I'm sure no one else was shocked by those kind of steps, and you weren't thinking, well, of course they would. But from that perspective, just hearing you talking about challenging the very basis of your relationship with the people who see you as something different to a statutory provider by saying the mode of care is not what you are saying is the right thing, is not what we think is the right thing. And the courage really that it took. And Alberto, you had something on your chart there about a very little bit at the bottom that said one of the great leadership skills you need is courage, really. And we heard earlier today a bit of hectoring of our leadership quality, saying it's up to us now to take charge and to step up to the plate. When you've had to do that job of speaking against the popular view, how have you managed to do that, really? What have you? I'll perhaps start with Richard on that one, given that you what have you done to to make sure you could do that well?
I mean, look, like I said earlier, there will be people here who have gone through this, who've changed service provision and so on, and it's horrible. It's I was with some families recently, and one of the services we're looking at closing is in Essex. There's about 45 people who live there. There was a couple there who were from Kent, and they said that they'd spent years looking for somewhere that was appropriate for their daughter to live. They'd eventually found this place in Essex. She's been living there for the last 15 years. They eventually got to a stage in their lives where they couldn't drive from Kent to Essex to visit her every week. And so last year they sold their house and moved to Essex. And 3 months later they got a letter from us saying we were going to be closing it. And you want to sit and cry with them when it's horrible. But you've got somehow I just keep having to keep believing that this is it's the right thing to do. And then you do get glimmers of when there was one meeting I was in with a lot of the families from one of these services, and during the break, you got a lot of abuse and shouted at, so. And one guy came up in the coffee break and said, could he just have a word outside? And he said, I've just sat here and for the last 2 hours, you've made me feel so incredibly guilty. And I said, why? And he said, your aspirations for my son are greater than mine have ever been. He said, all I've ever wanted for the last 30 years is for him to be looked after. And what you've made me realise is that I should have wanted more than that. And of course, but it's things like that when you realise that if you absolutely genuinely believe, and it's not just a feeling, the evidence, we know that a service for wheelchair users at the top of a hill is wrong. The way that you then change things, you've got to do that correctly as well, and invest in advocacy, invest in support, and so on. But it is a real challenge because charities aren't supposed to do that. And so that, we get hit a lot, and it's affected, there are lots of donors that have given us donations in the past that are stopping because they don't understand. So we're taking a big hit with it. But it's absolutely the right thing to do. And, and I think this is where, and I say again, I think there's, I get a lot of, whether it's courage or whatever, from the kinds of discussions that I will have with senior people in local authorities or with ADAS or Solace and so on about how you work together on this and about how we foster a better debate overall in the country about care, about the kind of lives that people want to live in, about why funding is really important. But it's also about changing the nature of the way that people are supported.
I was particularly conscious of that because of CCGs being membership organisations, and very often the first leadership challenge in the CCG is with the constituent practices about taking that step. And I think the bravery of people who've gone into CCG leading roles is under-recognised when it comes to what are you there to do, as opposed to make sure that general practices, the status quo in general practice is fine, but actually to change models of care. I think there's lots of parallels.
Let me just add, there's one local authority, not in London, that we're working with at the moment, and they want to close 10 very, very old-fashioned day centres in the next year. And we closed a day centre. Scope, for whatever reason, historically you all know how charities worked, but when I started at Scope I found that we owned and ran a farm, and it was, historically in this, it's Cornwall, and what had happened was a bus drove around Cornwall, picked up a load of disabled people and took them to the farm every day because somebody had decided that disabled people wanted to pet animals, and no one had asked them. So we closed this, and and there was we got a lot of stick for doing that because people just don't understand that a lot of the public were thinking, well, how can anyone take away that farm from those disabled people, but we did it in a really appropriate way. We worked with disabled people's organisations in Cornwall. Now we're working with Cornwall and the disabled people's organisations we work with, and the people who are now happier in their daily lives, not having to go to a farm every day, to help the local authority change.
I quite like the idea of translating that for GPs, actually. And, I think there's something about getting some GPs into farms every... No, so I'm being flippant. Albert... Alberto, so this point about courageous leadership, and obviously you were a pioneer in Spain with a new model in a system that was very nationalised like the UK system. How did you sort of like steel yourself for those kind of conversations and those discussions with the population in Alzira?
Yo desde luego, yo diría que lo que con los años he visto los 2 o 3 elementos más importantes. Primero es, no teníamos muchas respuestas para todas las preguntas.
So to add to the challenges and through the years, he's realized that there are not always answers to all the questions.
Pero la valentía estaba en que teníamos muy claro que nuestro objetivo era dar el mejor servicio a la población y teníamos que poner todos los recursos para conseguirlo.
But the one thing that remained a constant was knowing that their vision was to deliver the best value to the patients and needing to put all the resources possible in aim of that vision.
Luego, darnos cuenta que no estábamos allí para hacer las cosas como siempre se habían hecho. Teníamos el convencimiento que debíamos de cambiar el modo de organizar la sanidad y hacer una gestión diferente.
It's also understanding and accepting the fact and almost embracing it that they were going to do something different. So everyone knew that this wasn't the normal way of doing things. They were going to do something different and accepting that.
Y esa ambición además la hemos mantenido en el tiempo. O sea, nosotros creemos que todavía hoy tenemos muchas áreas que tenemos que seguir mejorando y sobre todo individualizar el trato al ciudadano.
And that vision is still alive and well today. So it's still continuously improving and still always thinking about what else can we do that's a bit different, that would still deliver that value for that bit extra.
Porque al final, en todos estos debates, lo que tenemos que ser muy claros es que todos trabajamos para el ciudadano. El ciudadano es ya no es el centro de la atención, pero es al que tenemos que dedicar todo nuestro conocimiento y nuestra sabiduría en conseguir que el ciudadano le demos la atención en el siglo XXI, una atención del siglo XXI. No podemos gestionar como hace 50 años.
We can't work the same way that we did 50 years ago. We need to work in the 21st century the way that the 21st century works, and it's knowing that at the end of the day, it's the patient and the citizen that's at the heart of everything that they do. So it's thinking about how do you reach them, how do you provide the best service.
Okay. I think that on that point, that's a great point to note. So can I ask you to thank our panel? So